Hey everybody, hope that you're doing well and I hope you're ready to go over another exam item. I chose this particular question because this is a question that I found to be relatively applicable to both my first year students and my second year students. So I'm covering cardiopulmonary anatomy and physiology with my first year students right now, and my second year students, we're going over some board exam review prep information material to get them ready to go because in about 8 weeks they'll 8 weeks or so, they'll be getting much closer to being able to challenge their MBRC board exams and hopefully go on and earn their registry and what have you. So in the cardiopulmonary anatomy and physiology course, we've been covering, respiratory anatomy, mechanics of ventilation, the difference between ventilation and perfusion. We've talked about shunt. We've talked about dead space. You also are taking cardiopulmonary pathophysiology. So we can really apply quite a bit of what's been learned throughout the program to this question here completely for the second year student and get you a head start on what will be expected of you and how you can begin to apply the information that you're learning, excuse me, that you're beginning to or that you are learning uh, as we move forward, and hopefully you can hopefully ultimately help it all tie together. So let's go through and read the question first. You're providing care for an ARDS patient that has bilateral infiltrates in the lower lobes. The patient is hypotensive, systolic pressure is 95 millimeters of mercury, diastolic pressure is 58 millimeters of mercury, and the patient is receiving conventional ventilation via the following. Assist control, pressure control, you have a set rate of 14, a total rate of 14, a peak inspiratory pressure of 31 centimeters of water pressure, a PEEP of 19 centimeters of water pressure, an FiO2 of 1.0 or 100%, and an inspiratory time of 1.2 seconds. Our arterial blood gas results are 7.39. Our PaCO2 is 45 millimeters of mercury. Our PaO2 is 53 millimeters of mercury. Our bicarb is 24 milliequivalents per liter. And then it follows up with the actual question: which of the following is the best recommendation for this patient? Is it to decrease the PEEP to 17 centimeters water pressure, prone the patient, administer hydralazine, increase the peak inspiratory pressure to 33 centimeters of water pressure? So now let's kind of go through and break down the components of the question that are important, or basically things that teach from and kind of show you where uh, and pinpoint for my students where they've probably learned some of this stuff. So right off the bat, ARDS, your cardiopulmonary pathophysiology course, and any other course that you've taken where we've tried to tie things in with disease processes. We know that in the world of respiratory therapy, we're taking care of individuals that are going to have compliance issues, resistance issues, elastance issues, or what have you. But we've got two different umbrellas really that we work from. So we have obstructive disorders, we have restrictive disorders, and then there are some disorders that may provide a little bit of a combination of both, some restrictive capacities and some um, obstructive issues that come along with it too. But for our purposes, we've tried to delineate what is obstruction, what is restriction, and so forth. So we're told that this patient has ARDS, acute respiratory distress syndrome. That is a well-known restrictive disorder, and we know that we get destruction of alveolar capillary membrane. We get the bilateral infiltrates. It's also mentioned right there in the question stem that you have bilateral infiltrates in the lower lobe. Now, how do we know that we have bilateral infiltrates? You're going to listen to them and say, the patient got bilateral infiltrates? Probably not. You've got to have a chest X-ray in order to do that. So we've also gone over radiographic examination and components of various classes that we've had already, where we're looking for an increase in radiolucency if it's a more air-filled space, or more radiopaqueness if it's a shows up a different shade of gray and or white on the monitor itself. So we know that as far as X-ray is concerned, we're going to have an increase in opacity on both sides with bilateral infiltrates. That's also going to bring about at areas of atelectasis consolidation and alveolar collapse, which is the atelectasis. We also know if we attribute what we've learned in class, that along with those disorders, or along with ARDS and along with everything else that we just mentioned, if I've got an alveolar unit that's closed down, it will still have circulation through the capillary network that surrounds that. So we'll have a situation where there's circulation or perfusion without ventilation. There's perfusion without ventilation. That is shunt. And then remember, if you have ventilation without perfusion, that's dead space. But in this situation, we've got an increase in shunt. So now we got to remember, what does shunt mean? Shunt is when you have deoxygenated blood mixing with more oxygenated blood. So if I have blood that goes around this collapsed alveolus, and we know that the alveolar capillary membrane is a site of gas exchange. O2 is supposed to go into the blood, CO2 into the alveolus, so that when you exhale, you can breathe out your CO2. And as we've breathed in, we've taken in the oxygen that can hopefully go back into the bloodstream and then get transported over through the left side of the heart so that it can be recycled around the body and deliver the O2 to where those specific needs are. Um, so in this situation, the blood flow has gone through that alveolus that's not receiving any ventilation. It was deoxygenated as it's making its way around that alveolus or through that capillary network. It never participated in gas exchange. So that deoxygenated blood is going to eventually be mixed back with the blood that did get oxygenated, and then that's going to decrease the total amount of oxygen that's going out to the rest of the body into systemic circulation. So the bilateral infiltrates we've covered, ARDS we've covered as a restrictive disorder. You're going to have a decrease in lung compliance. So it's maybe going to be a bit more difficult to ventilate those individuals. And ventilate by ventilation, I'm talking about the removal of CO2. It may also be difficult to oxygenate those individuals because of what we just talked about with that alveolar consolidation, atelectasis, the infiltrates that are going to be there as well. Uh, So we think back to the very first part of the respiratory program, back when we went over our medical terminology and such. So we're tagged with a term right there off the bat, hypotensive. Now you're given some numeric values to hopefully help lead you to where that is, but tension or if a patient's hypotensive, you got to understand that their blood pressure is low. And we can see that if you look at a normal blood pressure with a systolic being 120 millimeters of mercury, your diastolic being roughly 80 millimeters of mercury, that your systolic and diastolic numbers are on the lower end. So numerically, with what's presented, it makes sense that this patient is hypotensive or that their blood pressure is low. We also see that the patient is receiving conventional ventilation. So they're receiving conventional, it doesn't mean it's high frequency ventilation, doesn't mean it's or anything that is conventional ventilation. So you're utilizing a conventional mode of ventilation to treat these individuals. So for my second year students, all of this should hopefully make sense. For my first year students, you're about 8 or 9 weeks away from this stuff beginning to make sense, but trying to put it all together for you where you're going to see it at. So we do have different types of or different modes of ventilators. There are also different types of ventilators out there. Uh, Not going to get into all of the modes right now. We will cover that this summer once we get there. But what we're looking at here is assist control, pressure control. So in assist control, pressure control, or those assist control modes of ventilation, what we have to understand is you will have some set parameters and you will have some measured parameters. We also have to understand that in pressure control ventilation, that is your control variable. So you will have direct control over your pressure, but your volume, because it's dependent upon lung compliance, your volume will vary. So pressure is constant while volume varies. If this were ACVC, assist control, volume control, volume would now be your constant variable. So you would set a tidal volume with that. With your volume being constant, guess what would fluctuate now? Your pressures are going to fluctuate up and down. So that's the quick gist, nuts and bolts of ACPC versus ACVC, and we understand that we've got set things in set parameters in there and measured parameters. Also, in addition to that, can the patient trigger over the set rate? Yes, that patient can trigger over the set rate. Is this patient triggering over the set rate? Our set rate is 14. Our total rate is 14. If you subtract those, the answer is 0. So no, this patient is not breathing any over the set rate. So this means every breath, uh, the patient's just breathing at the set rate. So for all 14 of breaths of the set respiratory rate, they're all going to be delivered at 31 centimeters of water pressure, 19 a peep for 1.2 seconds I time with 100%. If the patient were to trigger a 15th, 16th, or 17th, and so on breath, those additional breaths will also be delivered at the same thing. So if you hear somebody talk about that, those being machine breaths, mandatory breaths, ventilator breaths, or what have you, the patient can trigger them, but the machine's still doing all the work to get it to them. But the patient can say, "Hey, I want more than the 14 you're telling me I can have." But then all of that's going to be delivered with what the ventilator has set. So that's something that we're going to need to make sure that we understand. My second year students should pretty well understand that, and the first year students, you're going to get to understand that pretty well when we go through here in a few weeks. So those ventilator settings, your peak inspiratory pressure, that's up there a little bit. Our PEEP is up. We also know our PEEP is elevated and FiO2 is 100%, and the patient's hypotensive. So we might would want to look at our, um, our optimal PEEP settings and stuff like that. If we had enough information to be able to identify that, we do see that the patient's hypotensive. But nonetheless, let's take a peek at the blood gas. So we're given our pH, which is going to let us know if that blood gas is normal, acidotic, or alkalotic. And we got to know our ranges for that. So normal range for your pH is 7.35 to 7.45. Normal range for your CO2 is 35 to 45 millimeters of mercury. Your PaO2 should be 80 to 100 millimeters of mercury, and your bicarb should be 22 to 26 milliequivalents per liter. Now, I'm not going to get into acid-based disturbances or what have you here, but you got to understand those to be able to apply that to this question. For my first year students, we'll be going over arterial blood gases here in the next 4 or 5 weeks as that comes up on our of course, and I'll also put out a couple other videos, and I'll probably put out a few other videos with reference to blood gases, so you guys can look at one of those uh, if you need additional help or practice with arterial blood gas interpretation, trying to determine if it's compensated or not. You may also be asked eventually to calculate like an anion gap and so forth, and we'll talk about all of that at a later date. But in taking a peek at this blood gas, our pH is within normal range, our CO2 is within normal range, so our ventilation is appropriate at this point for the patient. Our PaO2 is 53. So I said 80 to 100 is 80 to 100 millimeters of mercury is normal for your PaO2, and then you have various degrees of hypoxemia below that. So uh, 60 to 79 millimeters of mercury would be considered mild. Uh, 40 to 59 will be considered moderate. And then anything that is less than 40 would be considered to be severe. So this individual has moderate hypoxemia. That 53 puts him right within that range. So he has moderate hypoxemia. And your bicarb is right in the middle of normal. So down here, when we look at the question says, which of the following is the best recommendation for this patient? Well, now as the test taker and the respiratory therapist that we're going to be, we have to determine, why do I need to make a recommendation? Obviously, I need to make a recommendation because I have four answer choices to choose from. But now I've got to figure out what the issue is. Patient has ARDS. You remember your pathology about ARDS. We talked about the increase in shunt, that you're going to have the mix up or the issues with ventilation and perfusion that's going to bring about. The bilateral infiltrates, we talked about that. The patient being hypotensive, we talked about that as well. So is the issue here what we have? Is the low blood pressure the primary problem? Is the set anything wrong with the settings that we got? Is that the primary problem? Is the blood gas the primary problem? So you can look at your answer choices and try to help figure out where we're going with things. But ultimately, if I look at this blood gas, this PaO2 being 53 is what I'm thinking in my mind I'm led with ARDS. I'm thinking I've got to try to find something that's going to address that oxygenation issue. And we can go through a few other things. So, for instance, and if we can remember, so which of the following is the best recommendation for this patient? The first thing I'm going to look at is it says decrease your PEEP to 17 centimeters of water pressure. If we're given this value that the PaO2, the patient has moderate hypoxemia with a PaO2 of 53 millimeters of mercury. So if I'm looking at everything here and I have a PEEP of 19, I do know that extra pressure inside the chest could eventually cause my patient to become uh, hemodynamically unstable or cause their blood pressure to drop. I know excessive pressures with the ventilator can cause that. But I also know that the PEEP coupled with the high FiO2 are supposed to help improve this. So right now, to drop the PEEP from 19 to 17, maybe that helps with this, but I've already determined in going through the question that blood pressure at this point in time is probably not my most significant problem, but instead that moderate hypoxemia level I have is so I'm not going to mark it out just yet. I'll come back to it, and if I don't like any of the answer choices or what have you, we'll look at it. Prone the patient. What benefit would proning the patient have for this individual? If I don't make any ventilator changes, they're bilateral infiltrates in the lower lobes, and if you can, so I would kind of draw the lung to it. So well, even over here on this picture, you can see that the anterior portion of those lungs are a bit more superior than the posterior portion of the lung. So if I were to draw the lung from like looking at the side, and you'll have to bear with me a little bit. So this being the anterior chest, posterior chest, you can see how these extend down a little bit further. And if you can remember ventilation perfusion, blood flow is going to favor the gravity dependent regions, while ventilation will typically travel the path of least resistance. So if I'm lying in the supine position, it's not unthinkable to think that my anterior chest is going to receive the overwhelming bulk of that ventilation, while the posterior chest or portion of the lungs is going to receive the overwhelming bulk of the uh, perfusion. So, or circulation. So if I have um, more infiltrated atelectatic consolidated alveoli in the posterior portion of my back, then I have ventilation. It makes sense. There's a lot of shunt. It makes sense that that's going to be a contributing factor to that low PaO2. So then if I were to take myself from a prone position and now rotate, or excuse me, a supine position, take myself from a supine position and rotate over to a prone position, that's now going to redistribute ventilation and perfusion. And hopefully that would help boost that oxygen. So I do like that as an answer choice, but I like to go through all of the answer choices that I have just to see if one is better than the other. Uh, and this particular answer choice addresses very specifically this PaO2. This answer choice would potentially make this worse, while it hopefully helps make that a little bit better, potentially. Administer hydralazine. Ooh, now I got to remember my pharmacology. So, and I know my first and second year students have had pharmacology. So we got to think about, well, what is hydralazine? What class of medication does it fall under, and what have you? So because you are a well-prepared future respiratory therapist or future respiratory therapist, so on, you remember that hydralazine falls under the vasodilator group. So if I give a vasodilator medication, what is going to happen to that right there? If I vasodilate, your blood pressure is going to tank even more. So that patient's going to go from just hypotensive to really hypotensive if you vasodilate that individual. So I don't like that as an answer choice. I'm going to mark that out. And then increase the peak inspiratory pressure from 31 centimeters of water pressure to 33 centimeters of water pressure. Well, it would be nice if they had given us some exhaled values, such as what the volume is or what have you, but we, being well-trained respiratory therapists, know that we are attentive to um, our ventilator settings to make sure that we can reduce the risk of barotrauma or volutrauma. Barotrauma being trauma that's caused by excessive pressures, volutrauma, excessive volumes, and so forth. But we also go back to the mode of ventilation that we're in. We know that if we're in pressure controlled ventilation, pressure is going to be constant while our volume is variable. And if we go back to the blood gas, we do not need to address a significant portion of ventilation. So our ventilation is not the problem with the blood gas. Uh, if we're looking solely at the blood gas, ventilation is not the issue. Oxygenation at the is an increase in peak inspiratory pressure going to directly address that? Well, some may argue about your increase in mean airway pressure and what have you. You could maybe extend out your I time. That's not an answer choice. You could inverse ratio ventilate your patient. You could do IRV on, not an answer choice. So we got to go with what we're given. In this particular scenario, increasing the PIP to 33 potentially worsens this, potentially causes barotrauma. So this is a potentially harmful answer choice given what we're being asked of. So I'm going to mark that out. So I narrowed it down between these two, decrease the PEEP to 17. While 95 is hypotensive, it'd been nice if it would have delineated if it's an adult patient, pediatric patient, what have you. We will assume, they have ARDS, it's an adult patient. Uh, if they'd given us an age, height, or whatever, that would have been fine. Uh, so dropping the PEEP to 17, I've deduced from everything that I've thought about with this question that the PaO2 is my primary problem. Dropping the PEEP to 17 is potentially going to worsen that problem for me. So I don't like that. Based upon everything I can remember about ARDS, the bilateral infiltrates, patient might be hypotensive. They're receiving conventional ventilation. What I know about conventional ventilation, what I know about arterial blood gases, what I know about the potential negative impacts of these other answer choices down here, I'm left to believe, or left with the only really safe choice that is going to directly potentially have a positive impact on this is to prone that patient, take them from the supine position, prone them, and then redistribute your ventilation and hopefully have better VQ matching when we do our ventilation perfusion matching. So while that was a long-winded approach to one question, and remember, if you take the TMC exam, you've got 160 questions and 180 minutes to answer those 160 questions. For my second year students that will be challenging that RTE exam, you're going to have 185 questions, and I believe it's 4 hours to take that, which 240 minutes. So you still need to make sure you're pacing yourself accordingly. So we can't take 25 minutes going through one question, but nonetheless, talk about the thought processes that you should be thinking about as you're answering these types of questions. And for my first and second year students and anybody else watching, I hope that you find it helpful. Thank you for your time, and I hope you have a good day.